Good day and a very welcome to our first real lesson on assessment of the fetal status using the cardiotachograph, and we are now in lesson 3 where we're going to talk about the electronic fetal monitoring, and this is part 1 of the slides where we're specifically going to talk about the cardiotachograph and the graph of the cardiotachograph. Now I hope you have enjoyed your quiz, and I hope that you have passed it, or I hope that you have failed it and really need the knowledge that we are going to do in the slides now. Now, as I've said in this lesson, we are going to talk about the cardiotachograph as such. It's a machine that has two transducers. The one picks up the fetal heart rate, and we usually position it on the maternal abdomen at the place where we can hear the fetal heart the best. And then it's been transmitted to a machine where it's been put over into a graph where we can read it as a graph and to determine the qualities of the fetal heart. And then the second transducer we place usually on the fundal part of the uterus where the contractions are the strongest, and this is the tachograph of the machine. It measures the contractions, and then it's also been relayed to the machine where it's been put into a graph. Now, if we just look at the fetal heart monitoring part, the fetal heart monitoring part works on a ultrasound-based principle, a Doppler principle, where the transducer picks up the cardiac movement and convert then the signal to a trace line on the CTG, as we can see. We can do it both externally and internally. The photo that you've seen on the previous slide is obviously the external method of doing the CTG, and I will show to you the internal part just now where we require electrode that does basically exactly the same, also works on an ultrasound based principle, and it also relays the fetal heart to a graph. Now, because this fetal heart rate transducer works on an ultrasound basis, we need to put some gel on the maternal abdomen in order to transmit the fetal heart movement, or the movement of the fetal heart into ultrasound, through ultrasound to the machine, while we don't need any gel for the transducer for the contraction part. Now, as I've said, we usually put the transducer at the place where we hear the fetal heart rate the best. So we obviously have to do an abdominal palpation before we can put the fetal heart monitoring part of the tachograph on the patient's abdomen, and then usually we put the transducer more or less where we felt the anterior shoulder is usually the best place to put the transducer. Now, if we look at the contraction part, the tachograph part of the cardiotachograph, the cardio part is the fetal heart part, and the tachograph part is the contractions part. Now, here we have this transducer that measures the contractions, and here in the middle part, we have this very pressure sensitive dynamometer. It's basically picking up when the maternal abdomen, when the uterus contracts and the maternal abdomen becomes harder, it picks up that differences and transmit it over to the machine where it can be put over into a graph. Now, what is very important here is that the tightness of the belts to a very large extent determines the quality of the curve. If it's too tight, then we don't get a proper curve, and when it's too loose also. Now, I will come in lesson 5 when we do the interpretation of the cardiotachograph again to the importance of also having a very good monitoring of contractions. One so often see sees graphs where only the fetal heart has been monitored. Now, during the antenatal period, that's not the biggest problem because it's only the fetal heart that we're mostly interested in. But during labor, it's very, very, very important that we have a good quality graph of the contractions as well. Now, I do understand that sometimes the mothers are restless and it's painful and they move a lot, and that also has an influence on the quality of the contractions. But it's very important, as I've said, to try and get as much as possible a good graph of the contractions as well, because that gives us very important information that we need to interpret our CTG correctly. It helps us to determine the type of decelerations. It helps us to determine whether there are too many contractions or not, which all might play a role in the development of fetal compromise. Now, if we go on further to the contraction part, what is very important about the contraction part is that the external tachograph can only detect the frequency of the contractions correctly or accurately rather. With the internal method or with the internal uterine pressure catheter, it's much easier, and I will explain that in just the next slide, I think, a little bit more in detail. But with the external tachograph, we do get the graph, as you can see here a little bit, we get that the uterus contracts and then relaxes, and then we have this waveform graph here on the CTG. So we to a certain extent can determine the duration of the contractions. We can to a certain extent see whether the contractions are strong or not, but that is not very accurate because it's basically on the outside of the maternal abdomen, and it can't really measure the correct pressures into the uterus. So we can determine the frequency of the contractions, which is very important for us, because too many contractions is very important. When we do the physiology of the CTG, you will understand that also to a large extent. Now, we set the baseline of the contractions on the CTG machine. And that is very important for us because that gives us a baseline to see where the contractions after the uterus have contracted, whether the uterus relaxes to the baseline of the contractions again. So we set, as I've set it on the machine, we set it at 20 to 10 or 10 to 20 millimeters mercury, and that does not denote the intrauterine pressure that's in the uterus. Now we know that between contractions there's still a little bit of pressure in the uterus because there's still some of the uterine muscles that contracts, that makes that there's a baseline pressure in the uterus between contractions. Now this is not the measurement of that pressure. It just gives us literally a baseline to see whether the contractions come back to the baseline, whether it relaxes basically to the baseline. And that's why we set this baseline during a uterine relaxation phase. So that gives us more or less an indication that the uterus relaxes to its previous relaxation phase. Now, just again, as I've said previously, the quality of the signal to a very large extent depend on the proper placement of the belts and how tight the belts are, and also to a large extent when the patient is obese and there's a layer of fat, it might also influence the quality of the contraction monitoring, if I can put it like that. Now, as I've said previously, we usually put this transducer, the tachometer, on the fundal part of the uterus, because that's usually where the contractions are the strongest, and that's also usually where the contractions start. Now, it's sometimes also necessary for us to monitor the fetal movements, and this is specifically important for us when we do a non-stress test during the antenatal period. And when we come to antenatal fetal monitoring, we will discuss this in much more detail. But to be able to determine whether there are fetal movements and when exactly the fetal movements happen, the mother gets a event, what we call an event marker, and she presses this button every time that she's aware of a fetal movement. It will then be marked on the paper, and then we can see how the fetal heart reacts towards that fetal movement, whether there's an acceleration or whether the fetal heart doesn't accelerate, etc., which is very important for us during the antenatal fetal monitoring. Then another very important aspect on the CTG for us, both antenatally as well as during labor, but specifically during labor, is the maternal pulse. It might sound very kind of obvious that you won't really confuse the maternal pulse and the fetal pulse, but it is very easy to confuse it, and I will show you in one of the further on lessons graph where it has been confused. Because what happens often during labor is that the maternal heart rate increases because of the stress of labor, etc. And specifically when there's a maternal hemorrhage, obviously the maternal heart rate will accelerate as well. And then we get that in some cases the fetal heart rate goes slower and we have a bradycardia, and then we sit with the maternal heart rate of around 100 beats per 110 beats per minute and a fetal heart rate of about 100 to 110 beats per minute. And then it's very easy to confuse the two with each other. Now, in some machines, we can record the maternal heart rate separately, and it's been presented on a graph, and I will show you that to you also just now. Or if we have a machine, or we have a little bit of an old-fashioned machine where we can't record the maternal heart, it has to be done manually. So the moment that you put the CTG machine on the fetus and you get a good accurate recording of the fetal heart, it's a good time to just feel manually the maternal pulse, determine the rate of the maternal pulse, and to write it down on your graph to show that you have done it and to show that there's a clear difference between the fetal heart and the maternal heart. Then when we get to the internal method of the cardiotachograph that I have spoken briefly about previously, here you can see a diagram of it. Here is the intrauterine catheter that goes past the presenting part, so you can see that the membranes have to be ruptured in order for the internal method to be applied. So this internal catheter goes past the presenting part and it comes to lie here in this pool of liquor. And that is what makes it so accurate. So it can accurately determine the pressures in this liquor and then put it over in a graph, and then it enables you to measure the pressure in the uterus as well as the duration of the contractions. You will see you can accurately measure the baseline of the uterus, what's going on in the uterus between contractions, etc. And then in order to measure the fetal heart, we have to apply a very thin electrode to the fetal scalp, where it also picks up the cardiac movements, and it works, as I've said previously, on an ultrasound Doppler method, where it transmits then to the machine and where it's been put over into a graph. Now, if we look at the graph, and this is a very important specifically for people who do this, who are basically beginners in the interpretation of a CTG, I think there are some very important things to understand on the fetal graph before we can accurately interpret it. Now, the graph, the principle of the graph always look more or less the same. It differs a little bit according to the brand of the paper. We get different brands of paper, but as I've said, the principles are more or less the same. We have a contraction part where the contractions are being monitored at the bottom, and then we have a bigger part at the top where the fetal heart rate is being recorded, and in this case the maternal pulse as well. So just a few very important things to take into consideration when we do interpret the graph is this is, as I've said, the fetal heart part, and these numbers represent then the fetal heart rates. So here we can see it comes from about 60 beats per minute and it goes up to 200 beats per minute, and this tells us then what the fetal heart rate is. So if we look at this fetal heart rate, here more or less is 140 beats per minute, so it tells us that this fetal heart is more or less 140 beats per minute. Then the other very important thing is the rate of the machine, the rate that, or the speed that the machine has been set on, because that gives us a time indication. Now, this you will see on, and this also differs depending on the brand of the paper, but on most papers there are some darker lines, a lighter line and a darker line. And the distance between these two darker lines is usually 1 centimeter. Now we can set the machine to at different speeds or at different rates, depending on what you want to call it, of 1 centimeter per minute, 2 centimeters per minute, or 3 centimeters per minute. And what it means is that this paper goes through the machine at the rate of 1 centimeter per minute, or 2 centimeters per minute, or 3 centimeters per minute. And the only thing that differs then is that because this is 1 centimeter, so if we read the graph over this 1 centimeter, it looks a little bit different than when we read that same graph, that part here, over 3 centimeter per minute, and it just basically looks a little bit stretched out. So it's very important before we start interpreting a fetal, the CTG graph, that we make sure, and it's always been printed here between the fetal heart and this contraction part, at what rate the machine has been set. It also helps us then to determine, if we want to determine, for example, how long that acceleration was, we can see it's almost a minute long. It helps us to determine, although I've said we can't accurately determine the duration of the contractions, but it to a certain extent can also help us to determine more or less what the duration of the contractions were. Now also what's important then is a 10 centimeter period, because that's how we determine the frequency of contractions. We usually determine how many contractions are there in a 10-minute period. So 10 centimeters, 10 of these centimeters will give us then a 10-minute period. And usually also depending on the brand of the paper, it's usually between these two rows of numbers here on the fetal heart part, and this gives us a 10 centimeter period. So we can determine how many fetal movements are there in 10 centimeters, we can determine how many fetal contractions there are, etc. Then this is the graph of the fetal heart, as I've said, and we can determine all the different characteristics which we will come on regarding the fetal heart rate. Now here in the middle part of the CTG graph is not only the rate of the speed of the machine, that how fast this paper is going through the machine, but we can also see here a time and a date. So this cardiotachograph has been done at 7:40 on the 5th of August 2018. Now, this is very important for us, and when we set up the machine, and we will talk about that in the next part, it's very important to set this time and date correctly, because we are also going to record on the maternal records, and if the two times do not correspond with each other, then we have a little bit of a problem. So this is the time, and it's very important that this should be set correctly, and we use it to interpret the CTG to a very large extent all the time as well. This part is the uterine contraction part, as I've said. And here we can see the uterus relax, and then the uterus contracts, and there's a contraction, relax, and contraction again. Now, I've talked about setting the baseline. Here you can see the baseline has been set on, this is the millimeters mercury that we use to determine the amplitude, the strength of the contraction, but seeing that we mostly only use the external mode of the CTG in South Africa, we don't really use this because, as I've said previously, we can't accurately determine the strength of the contractions, the amplitude of the contractions. But we use this to set our baseline. So when the uterus relaxes, we set the baseline on between 10 and 20 millimeters mercury, so that we can see here's the baseline, and every time after a contraction, the uterus relaxes back to the baseline that we have set. And then the H part here is the maternal pulse. It records the maternal pulse. This machine was able to record the maternal pulse, and here we can see the maternal pulse is in the area of about 80 beats per minute, and we can see the clear difference between the maternal pulse and the fetal heart there. And that brings us to the end of lesson 3, part 1. And then in the next part 2, we will continue on different aspects of the CTG and to prepare the patient correctly for the CTG, etc.